What's up, Ninja Nerds? In this video today, we're going to be talking about acute respiratory distress syndrome, also known as ARDS. This is a part of our clinical medicine section, and if you guys like it, please support us, and you can do that by hitting that like button, commenting down in the comment section, and please subscribe. Also, if you guys get a chance, go down in the description box below. I really urge you guys to go to our website, become a member. There we have a lot of cool stuff. We got notes, illustrations. We're developing question banks. We're even developing exam prep courses for those of you who are taking your boards. And we got some cool merchandise, so go check that out. How do we define this? This is an interesting type of disorder. Usually in these patients, they have some type of very particular findings. And you can remember that via ARDS. There is acute hypoxemia. There is acute hypoxemia. So that SpO2 is usually either less than, 90% in patients who develop acute respiratory failure, or their PaO2 is less than 60 millimeters of mercury if you're getting it off of an ABG. The other finding is that they're exhibiting potential other signs, like what? Well, one of the other particular things is they're exhibiting signs of a ratio that is determining of the degree of their hypoxemia. And we'll talk about this a little bit more in the diagnostic section, but we say that their ratio, which is determining their PF ratio, has to be less than 300 to also consider these patients to have ARDS. So they have to have acute hypoxemia, meaning it developed within less than a week. Let's also add that in. Less than 1 week since the particular trigger. A ratio that determines the severity of their hypoxemia, which is a PF less than 300, and they have to have diffuse infiltrates in their chest. So there has to be diffuse bilateral infiltrates. What the heck that mean, man? That means if you look at these patients' chest x-ray or their CT scan, you're gonna see all of these like white types of opacities all throughout both of the actual lung fields. Now, whenever you see that, you see all these like bilateral opacities on imaging. On top of that, hypoxemia that developed within less than a week, a PF ratio off their ABG that suggests that it's less than 300, you then need to say, could it be cardiogenic pulmonary edema that we're seeing? How do I really rule that out? Well, the most definitive test is that you do what's called a Swan-Ganz catheter. And that places this into the pulmonary capillaries and gives you a wedge pressure. And if that pulmonary capillary wedge pressure is less than 18, that is the most definitive way of saying that there is no cardiogenic pulmonary edema. So this would say that there is no cardiogenic pulmonary edema. There is other ways, and I would suggest that you do other things before going to a SWAN. Usually these are going to be things like an echocardiogram. That would also probably be the more likely thing. But again, this is one of the most definitive ways to say that there's no cardiogenic pulmonary edema. Now, this patient has these particular findings. This is what we call the Berlin criteria of ARDS. But we have to then go and say, okay, they have acute hypoxemia developed within less than a week. It shows a PF ratio less than 300. They have diffuse infiltrates, and they have no cardiogenic pulmonary edema that's causing these bilateral infiltrates. What in the heck is going on? Why are these infiltrates here causing all these problems? Let's say here we take an alveoli. Here's a normal alveoli, has type 1, type 2 alveolar cells. All of a sudden, we decide to cause some diffuse alveolar damage. We injure the type 1 cells, the type 2 cells, the pulmonary capillaries. We jack all these things up. And we're going to represent that by what's called a diffuse alveolar damage. We also sometimes just abbreviate this as DAD. So diffuse alveolar damage is going to occur here. When this occurs, we're going to damage different types of cells. Let's say in this scenario, we go down this pathway and we damage the type 1 cells. You know, the type 1 cells are squamous cells. They're supposed to participate in gas exchange, and they maintain a good barrier between the alveoli and the pulmonary capillary. If you destroy them suckers, now guess what? Fluid can easily leak out here and right into what? Right into this poor alveoli. And this thing can start filling up with fluid, right? So let's lay down some things that it can actually start filling up with. It may start layering up here and filling up with fluid. That's one particular thing. It may start layering up with proteins. It may start accumulating a lot of different types of immune system cells that'll accumulate in this particular vicinity. And then on top of that, there may be a lot of proteins. So we'll put some proteins here within this kind of like this pinkish color. So now you end up with all this filling that occurs within this actual alveolus. So within this first injury here, what happens? You end up with what's called a lot of exudate. Exudative phase. And what this means is you're taking and filling these alveoli with tons of fluid and cells and a bunch of other types of chemicals. and this thing starts getting super, super filled. What's the problem with that? Well, imagine here we take this scenario where you fill this alveoli up, and now it's filled up with fluid and cells and maybe other kinds of things as well. Can you even ventilate this alveoli? No, you can't ventilate this dang alveoli. So because of that, there's going to be very, very poor ventilation. There'll be almost no ventilation. And if there's no ventilation and somewhat normal perfusion, what do we have here? We have the most extreme low VQ mismatch. That's what we call a shunt. And if ventilation can't occur, are you going to be able to get any oxygen into this actual capillary bed? No. And so what happens is blood is flowing through here because the perfusion remains relatively normal. When it leaves, because no gas exchange is actually even occurring here, what's going to happen to your PaO2 or your O2? It is going to drop. And these patients will have profound hypoxemia. What do patients look like when they have significant hypoxemia? Well, they start breathing really, really fast. And so what happens to the respiratory rate? It goes up. What happens to the work of breathing? It goes up. How do they feel? They feel very short of breath. And so these are very, very common features that usually occur as a result of the patient's hypoxemia. All right, so we see one way that they can develop profound hypoxemia and filling. This is an infiltrate. If this happens in multiple alveoli in all parts of the lungs, do you see why this can cause this diffuse infiltrates? Here's another thing. That's not the only thing. It causes diffuse alveolar damage and hits the type 2 cells. So let's come down and see what it does there. This thing jacks up the type 2 cells. And if we jack up the type 2 cells, you have to remember, what do the type 2 cells do? These are cuboidal cells. And they make a molecule here called surfactant. It's supposed to coat this. But if all of a sudden you start leading to less of these type 2 cells, do you keep all that surfactant that coats the inner parts of the alveoli and make sure that what? It doesn't collapse? No. So when you have type 2 cell injury, what happens is you lead to a decrease in the surfactant. And if you decrease the surfactant, you then have surface tension begin to rise. And as surface tension begins to rise in combination, if you're having both of these cells being damaged, fluid will also begin to accumulate here. So you're going to have fluid from what we just talked about above. So now imagine having fluid here, and then on top of that, imagine having less surfactant. What's going to happen is the alveoli will start to collapse because the surface tension rises. And then you're going to get here an example of a pulmonary shunt because what? You're going to have alveolar collapse. And now you're going to have this problem where the alveoli can't stay open because the surfactant is pretty much lost and it's going to be filled with a bunch of fluid. If you collapse these alveoli pretty intensely, what's going to happen? Are you going to get any ventilation at all into this poor little alveoli? No. As a result, perfusion could be somewhat normal running through here, but if the ventilation is poor, are you going to be able to get any oxygen over here? No. And so because of that, the ventilation is lost even though the perfusion remains somewhat normal. And so because of that, they'll have a significant drop in their oxygen because of no ventilation and relatively normal perfusion. And as a result, the patient's respiratory rate will go up, their work of breathing will go up, and attempts to be able to hopefully increase their amount of oxygen. But if the disease doesn't improve, that won't help, and this will just make them look like they're in more distress. So now we have an understanding here of this patient. They're developing shunting because of two processes. One, they're developing a shunt because of alveolar collapse, because of decreased surfactant. Or they're developing a pulmonary shunt because of an exudative phase. And if there's an increase in this exudative phase, this will cause this alveoli to get filled. And if the alveoli fills, that'll cause that shunt. So there's also going to be, again, alveolar filling. And that alveolar filling is what is precipitating this pulmonary shunt. We have to then ask ourselves the question, okay, what is causing the diffuse alveolar damage? What's leading to this type 1 and type 2 cell injury, which is causing shunting of oxygen, where you're not getting oxygen moving across the alveoli into the blood? The primary problem is that we're having some direct lung injury or indirect lung injury, and it is massive. What's the direct lung injury causes? It's something that we're inhaling or we aspirate, and this comes down here and it directly injures these alveoli, all these alveoli, type 1, type 2, they get all jacked up. And even some of it even spreads out here and hits some of these capillary beds. What would be some things that could actually be inhaled or aspirated into our airway? All right, I just gave you kind of the answer. One is pneumonia. This is a huge one. You guys know which pneumonia is really, really a big one now? SARS-CoV-2, or used to be kind of a big one. And the other one here is going to be aspiration. Aspiration's a really big one. And then finally, inhaled toxins. So if you have inhaled toxins, this is another really big one. For example, like a fire, there's a fire in a house and you inhale a lot of that soot, that can definitely do that. So these are three big things here that I want you guys to remember that can directly damage these cells. If you damage them, you see the result that can occur. But you have to damage a lot of them. The other one, and it's not being inhaled or brought in via the lungs, it has to be spreading through the bloodstream. And then as it spreads through the bloodstream, it diffuses out into the lung area and damages the capillaries here and damages the lung tissue. This has to be something systemic. What kind of systemic features would cause this type of massive inflammation? I can already tell you, a bacterial infection, systemic bacterial infections, which we call sepsis. Another one is a massive inflammatory condition that we call pancreatitis. And another one that is potential, but I would say it's relatively less common, but it is something to think about for your boards, is when a patient gets a transfusion and they have a significant reaction to that, and it really, really injures the lungs. And we call that a TRALI, a transfusion-associated lung injury. These would be the particular things where these are going to massively increase inflammation, systemic inflammation. So let's put that here. This is systemic inflammation. And that systemic inflammation just happens to run through the capillaries in the pulmonary area and lead to this diffuse alveolar damage. Whereas direct lung injury will cause direct local injury. That's the concepts I want you to understand about ARDS. Now that we've gone through ARDS, the particular definition, the pathophys, the causes, what are some of the potential complications that can happen either from this disease or the things that we do to treat this disease? All right, my friends, so the patient who has ARDS, acute hypoxemic less than a week, PF ratio less than 300, they have diffuse infiltrates, and their SWAN or echo suggests non-cardiogenic pulmonary edema. They have these bilateral infiltrates that are causing refractory hypoxemia. And now, with their signs of respiratory distress, we're going to have to notice potential complications that can arise within these patients. One of the big ones that I think is important to remember, because there is a treatment process that we can use for this, is pulmonary hypertension. In patients who develop ARDS, what happens is they have this intense refractory hypoxemia. And that hypoxemia that happens as a result of them having this pulmonary shunting process leads to intense, and I mean intense, hypoxic vasoconstriction. So what happens is this comes over to these pulmonary vessels and these things clamp down. So they develop an intense vasoconstriction. So that's one of the things that hypoxia can do, is it can really intensely contract down on these pulmonary vessels. If I stimulate this intense pulmonary vasoconstriction, what happens as a result is the pulmonary vessels get really, really small and narrow, and that increases the pulmonary vascular resistance, right? So now my pulmonary vascular resistance will go up, the pulmonary artery pressures will go up as well. So what will I notice? The pulmonary vascular resistance will go up, and the patient can start having high pulmonary artery pressures, which is called pulmonary hypertension. One of the downstream effects of this is twofold. One is if these pulmonary vessels are super vasoconstricted, what does that do to the perfusion to those alveoli? It reduces it, so that can actually worsen VQ mismatch. That's one downstream effect. But the other thing is if this becomes persistent, this can really affect the right heart. And this can start causing patients to develop things like right heart failure. How does that look? Well, if the right heart fails to pump blood forward and it can't fill, in these particular scenarios, the central venous pressure begins to rise. And the blood will back up via the vena cava. And if it backs up via the vena cava, what will that look like? Well, one thing is it can cause jugular venous distension. It may cause hepatomegaly. It may cause ascites. And it may even cause pedal edema. So there's potential of right heart failure precipitating these findings, and a patient who develops severe ARDS causing intense vasoconstriction. But again, I want you to remember that if resistance is really high, the other problem here is that this can worsen VQ mismatch. This can actually increase your VQ mismatch, and that can worsen the hypoxemia. So that's the other kind of downstream effects of this, and this is very, very common in patients who develop ARDS. The other thing that I really want you to remember is these patients are usually, if they develop severe ARDS, they're intubated. All right, they're going to be working hard to breathe, they're going to have refractory hypoxemia, and it's just not going to be enough to manage these patients, usually with non-invasive ventilation, which we'll talk about. But if they get intubated, one of the downstream effects that happens when the patients are intubated for at least greater than 2 days, and if it's longer, obviously there's a higher risk, is this tube is a piece of plastic. It's foreign to the body. When you have something foreign within the body, it creates an opportunity for bacteria to grow. And bacteria can stick and form a biofilm on this thing. And then what happens is these bacteria can spread to multiple parts of the lung tissue. And now I have an opportunity where this ventilator tube has spread bacteria to multiple parts of my lung tissue. And now the downstream effect of this is these bacteria can lead to an infection. And if I cause an infection of these particular lungs now, that's related to the ventilator. And that's called a ventilator-associated pneumonia. The problem with this is these are some really nasty bugs. And usually nosocomial infections, the ones that you really want to watch out for here is going to be things like Pseudomonas. They can really grow some nasty bugs here, Pseudomonas. And another one called Staphylococcus aureus, especially the MRSA type, more of the MRSA category. These are very common as potential, factors here that could cause these types of infections. So again, that's one downstream effect. Patients with ARDS, usually they're intubated for a long period of time. And the longer they are intubated for more than 2 days, the higher the risk of bacterial colonization, the higher the risk of infection, and then therefore VAP. And that's definitely going to worsen their ARDS as well. Okay, next particular scenario here is a patient can be intubated. When they're intubated, not only does VAP potentially arise, but another thing is that they can actually have ventilator-induced lung injury. So not just the pneumonia. What happens to these patients is usually something that we're doing. So when we hook them up to the ventilator, we set particular components of the ventilator, modes and pressures and volumes and PEEP, et cetera, that we'll talk about. But one of the biggest complications is patients who have ARDS, they have very low lung compliance. And whenever we give them very high pressures, maybe that's in the form of PEEP, right? So whenever you increase the patient's PEEP maybe a little bit too much, and this is in a patient with decreased lung compliance. So their lungs just don't really want to expand. So they aren't very fond of getting all of this pressure. What can happen is the pressure inside of the airways can get pretty stinking high. And when the pressure inside of these airways start getting to the point of what we call the plateau pressure, so when the P plateau is greater than 30, that is enough that this can actually cause a lot of trauma and can start dissecting the alveolar walls. If you dissect the alveolar walls, what can start leaking out? Air. And where will that air leak out? Into the pleural cavity. And guess what you just increased the risk of? A pneumothorax. So this is a potential complication where these patients can develop as a result things like a pneumothorax, or it can leak into the mediastinum, which we call a pneumomediastinum. So a pneumothorax or a pneumomediastinum are potential complications from having just way too much PEEP or high airway pressures within the lungs that distend and dice and slice these alveoli. And then these can potentially result as a result of that complication. All right, so you can develop things like a pneumomediastinum or pneumothorax. All right, cool. That's one thing we got to watch out for when we put patients on these high modes of pressure on the ventilator, is really watching out to not get these plateau pressures too high. What about volume trauma? Right, so you take an alveoli that's diseased, decreased lung compliance. Right, so same concept here. But what I'm going to do is I'm going to give them very high volumes. So I'm going to try to increase their tidal volumes. But the problem is this is a patient who has very decreased lung compliance. They do not like their lungs to get all this volume and all this stretch. And so what happens is you push this tidal volume into them, and their alveoli will get all this volume and it'll over distend. And so now look at this alveoli. You have an over-distended alveoli. Now you might be like, oh, same thing, Zach, right? It's gonna blow this puppy. No. In this patient, when you over-distend these alveoli, you actually injure the type 1 and type 2 alveolar cells. And what that does is that causes these cells to start releasing more inflammatory mediators. And so now you get an increase in inflammation. You're like, what? How the heck? Yeah, and if you increase your inflammation, what do you think you're gonna do to this patient? You're gonna make them have more alveolar edema, more alveolar collapse, and you're going to decrease their lung compliance even more. So this is gonna be potentially a worsening factor here. So giving them too much volume can increase inflammation and can actually worsen their lung injury, and on top of that, stimulate an even worsening of decreasing lung compliance. So this is a thing that you gotta stay away from. Stay away from way too high tidal volumes and stay from way too high of an airway pressure. The other thing that you wanna do is you wanna make sure that you don't give them too little pressure. So you're like, Zach, how am I supposed to, I gotta keep this happy medium all the time? Yeah, it's really difficult. But I don't wanna give them to the point where I don't have enough PEEP. So here's a normal alveoli. All of a sudden, I take a patient and I really decrease the PEEP. When you decrease the PEEP in these patients who have very low lung compliance, what do you think is gonna happen? It's going to collapse. And we call that de-recruitment. So now look at this poor little alveoli, it collapsed. So this is gonna be an example of alveolar collapse. Our alveolar, we call this alveolar de-recruitment. So this is what happens when you really decrease the PEEP. Now here's the thing, whenever you take an alveoli and you go from this to this, what do you think is gonna happen? Now the patient has to take an even deeper breath in, and they're gonna have to work a lot harder to reinflate that alveoli. The problem with this is this will definitely increase a couple things. It'll increase their work of breathing, and believe it or not, that constant going from inflated to deflated, inflated to deflated, increases inflammation. You're like, man, I can't get away with anything here. So you're gonna increase inflammation, which is gonna do what? That's gonna decrease the lung compliance even more. And if you decrease the lung compliance and you have low PEEP, it's gonna cause, again, them to de-recruit. So they're gonna have to work harder. You're gonna cause them to become more inflamed and decrease their lung compliance. So don't have too high of airway pressure, don't have too low of an airway pressure, and don't give them too much tidal volume. The last particular scenario here, which is kind of seems paradoxical, is but you don't want to give them too much oxygen. You're like, what the? They got low oxygen, I gotta give them oxygen. You don't want to give them too much. So if you give a patient just these crazy high levels of what's called FiO2, so the fraction of inspired oxygen, so you give them way too much oxygen. When you give them very high levels of FiO2, the problem with that is that some alveoli that are actually somewhat healthy will take that, and these oxygen molecules will start getting turned into free radicals. And these little puppies here will start causing, what do you think? More damage to the alveoli. So what do you think is going to happen as a result with these free radicals? If you have more free radicals, you're going to increase tissue destruction. Increased tissue destruction leads to increased inflammation. Plus, weirdly enough, having too much oxygen actually can act as a pulmonary vasodilator, and that can worsen your VQ mismatch. So another concept that you actually want to watch out for is if you give way too much oxygen, oxygen can also cause increased VQ mismatch because it acts as a pulmonary vasodilator. So the concept that I want you guys to take away from all of this is a patient has ARDS. Really the complications that come from these patients is when we put them on the ventilator, because we can do a lot of harm if we're giving them way too much airway pressure and their plateaus go up. We give them too much tidal volume, we don't give them enough PEEP, or we give them way too much FiO2. So it's important to make sure that we don't allow these things to happen as to prevent the actual continued destruction of those lungs and worsening ARDS. Now let's talk about how to diagnose it and treat it. So then we move into the next one. We have a patient who maybe we think has ARDS. How do we determine that? Well, one of the biggest things, you have to have a patient who has been acutely hypoxemic, and it usually onset has been for at least less than a week. It hasn't been chronic. It's been within less than the past, usually sometimes 48 hours. You get an ABG. When you get an ABG, you look at the PF ratio. And this is basically what it says. You take the PaO2 off the ABG and you divide it by the FiO2, how much oxygen, percentage of oxygen you're giving them. If it's less than 300, that's really suggestive of ARDS. Let me give you a little bit of an example here. So again, PaO2 you get from the ABG. FiO2 is usually anywhere from 21% on room air to 100% depending upon the way that you're providing the oxygen. If I give you an example, I have a patient who has a PaO2 of 50 off their ABG, their FiO2 is 80%. You'll take this divided by 0.8 and it'll give you their PF ratio, which is 62. What the heck does that mean? Well, if you look at the patient who has a PF ratio than less than 300, we can kind of divvy this off into severity. If it's anywhere from 200 to 300, that's mild. If it's 100 to 200, that's moderate. And if it's less than 100, that's severe. So this patient right here would be considered to be severe ARDS. So you have to have acute hypoxemia less than a week. You have to have a PF ratio less than 300. And again, depending upon where it is, it'll tell you the severity. What else do you need? You need to then check and say, okay, I want to make sure that this patient doesn't have any kind of like hypoventilation or something weird like that. This would usually be what? ARDS is a type 1 respiratory failure. So this means it would be like a VQ mismatch or a true shunt. So in this particular scenario, it would definitely be suggestive of a kind of a shunt process. So what I would do is I would get a chest x-ray or a chest CT. And what would I see? On the chest x-ray, you would see a lot of like diffuse bilateral opacities. You see how it's all white here? It should be a lot darker. So this patient has diffuse bilateral opacities, all right, or bilateral pulmonary infiltrates. Same thing on the CT scan. Here's the right hemithorax, here's the left hemithorax. You can see all of this kind of diffuse white patchiness and a little bit of a pleural effusion here. This is really, really suggestive of diffuse bilateral pulmonary infiltrates. So the next thing you want to say is, okay, I have acute hypoxemia, PF ratio less than 300, I have diffuse bilateral pulmonary infiltrates. How do I know that that's not from cardiogenic pulmonary edema? A patient is in CHF and they're having fluid back up. Elevated pulmonary capillary wedge pressure is causing this. You can do a lot of different things. One of the best things to do is get an echo. Does their echo suggest that they have a normal left ventricular ejection fraction greater than 50%? Do they have a normal left ventricular end diastolic pressure? They don't have any diastolic dysfunction? It's probably not cardiogenic pulmonary edema. But if you're like, I still don't think that's good enough, then you can go the far, extreme and most invasive way and do what's called a Swan-Ganz catheter or right heart catheterization. You take a catheter, put it down through the right IJ into the pulmonary vessels, and then eventually you go and you get a pressure off the pulmonary capillaries. And if that pulmonary capillary wedge pressure is less than 18, it is again suggestive that it's not cardiogenic pulmonary edema. So this is not from the heart. Therefore, this patient likely has ARDS. So what are the 4 things that you need to diagnose ARDS? You need an acute onset less than 1 week. You need a PF ratio that is actually less than 300. You need diffuse bilateral infiltrates on chest x-ray or CT scan. And this last one, just to help it make it work, is you need a Swan-Ganz catheter that shows the pulmonary capillary wedge pressure less than 18. All this is telling you is it cannot be cardiogenic in origin. You don't have to do a Swan, you can do an echo. But again, those are the ways that we're going to diagnose a patient who has ARDS, which is a type of, one of the worst types of respiratory failure. That leads to the next step. If I have a patient on the ventilator, how the heck am I supposed to know how to manage them? Well, the first thing you want to know is what's the mode that we have the patient in. Are they in what's called CMV or controlled ventilation? So this is a mechanical ventilation strategy where we actually set the respiratory rate that we want for the patient to have, and we set the amount of tidal volume, the volume that we want to deliver into the lungs. This is usually good for a patient who is not taking spontaneous breaths. In the other scenario, if a patient is taking spontaneous breaths, we should let them breathe on their own. Don't let them be dependent upon the ventilator. And so this is usually what we call PSV. So it's called pressure support or patient-controlled ventilation, where you can actually allow for the patient to breathe at their own respiratory rate and their own tidal volume. All you do is you set the PEEP and the FiO2. That leads to the next step. Oftentimes in the exam, they may say, okay, you have a patient who is being ventilated, their PCO2 is really high. What do I do to reduce their PCO2? Well, I want you to remember 2 things. One is respiratory rate and tidal volume. If you increase the respiratory rate or you increase the tidal volume, it'll drop the PCO2. If you have to pick between the 2, respiratory rate is going to be the more effective one. Same way, test your knowledge. If the PCO2 is low, what do you need to do? Then you need to decrease the respiratory rate or decrease the tidal volume, because that will help to bring it up. You're just trying to reduce their ventilation. So PCO2 is tied to respiratory rate and tidal volume. The next one is PaO2. What if it's too high? Well, if the PaO2 is too high, that may sound dumb, but what do I want to do? Don't I want their oxygen to be really high? No, it's actually kind of dangerous. You want to reduce the PEEP or the FiO2, and that'll reduce the PaO2. Same scenario, PaO2 is low, increase the PEEP or increase the FiO2. That'll increase the PaO2. The concept behind PEEP is that here's an alveoli. It's not getting good ventilation. You give them a lot of pressure at the end of expiration, and they don't collapse. They stay stented open and big. So now they can perform good ventilation, and they can actually perform gas exchange. But if you take the PEEP away, they'll de-recruit, go back to that small size, and they won't perform good ventilation. So this keeps the alveoli stented open and able to perform gas exchange. That's one of the big things about PEEP. What about PIP? This is called positive inspiratory pressure, or peak inspiratory pressure. If the PIPs are really high, that means that there's a lot of resistance to airflow through the ventilator tube. Maybe it's a small tube, maybe it's kinked, maybe there's a lot of mucus within the tubing, or they're having intense bronchospasm. That's important to remember. If the PIPs are low, that means that there's probably something wrong with the ventilator circuit. There's probably an air leak somewhere. The big one here that I really want you to remember is called the plateau pressures. Plateau pressures are a measure of kind of the, if you take an inspiratory hold, it kind of gives you the pressure within the airway at the end of inspiration. So it's really important for helping to determine the risk of lung injury. If plateau pressures are really high, that means that the lung compliance is not very good. A patient likely has ARDS or pneumonia or things to that effect, or they're air trapping a lot. And so this is really dangerous. And so whenever patients have very, very high plateau pressures, it's important to reduce the tidal volume so you don't cause barotrauma to the lungs. The last thing I want to talk about is whenever you have a patient who maybe was intubated for a particular issue and you improve that underlying issue, you don't want them to be on a ventilator forever, so you want to get them liberated from it. And so what we do is what's called SBTs, or spontaneous breathing trials. And we look at a couple different things. Did they resolve the reason why they were intubated? And if they did, good, that's one thing. Second thing is their FiO2 requirements very, very minimal? Okay, good. Is their PEEP really, really minimal? Good. Is their RSBI, which is their rapid shallow breathing index, are they breathing really, really fast and not taking very good deep breaths? These are all things that would say that a patient would likely succeed and be able to be extubated. If they don't meet these criteria, you should probably not extubate them because they'll have a high risk of being re-intubated. Big things that I really want you to remember is ventilating a patient comes with complications. If you have really high tidal volumes in these patients, especially in ARDS, or really high plateau pressures, you can really rupture those alveoli and cause barotrauma. That's one really big thing. It can cause what's called ventilator-induced lung injury. You want to avoid that. The other thing is that you don't want to give them too much oxygen, because if you give them too much oxygen, you cause VQ mismatching, you cause a lot of free radical formation, a lot of inflammation. That can also worsen the actual lung disease. So avoid that. And lastly is that these patients are at high risk. The longer they remain intubated, the longer there is the risk for them to develop a VAP, a ventilator-associated pneumonia. So you want to try to liberate them as soon as you can from that. We've talked about how we treat respiratory failure. Let's kind of change gears and go to the worst case. We have a patient who has ARDS. How do we treat this? One of the biggest things is that these patients are likely going to be intubated, all right? And when they are intubated, they're going to be really air hungry. They're going to want to breathe really, really fast and take a lot of deep breaths. So you want to sedate these patients and get them to be synced up with the ventilator. You want them to be in CMV, where you can control the ventilator. So heavy sedation via propofol or midazolam is going to be the best way to go here. You also want to avoid them getting fluid overloaded. So you want to keep a normal volume status because you don't want to worsen any edema within those alveoli. And the last thing that you want to do here is that you really want to aim for what we call low tidal volume ventilation. This is important because we want to make sure that the tidal volumes that they're taking based upon studies to be less than 6 cc's per kilogram of ideal body weight. And if they're above that, they're at high risk of worsening their actual lung injury. We also want to make sure that their PEEP is decently high because that keeps those alveoli stented open and doesn't cause them to collapse. So that's really, really important to go back to that concept. We don't want this process here, de-recruitment. We only want recruitment. So that's a really, really important thing because we've seen that with this strategy, we've been able to reduce ventilator-induced lung injury and reduce mortality. High PEEP, same thing. You reduce atelectasis trauma and you reduce mortality. So it's really important to employ this step because it shows that you can reduce mortality. The next thing is, let's say that the patient is getting heavy sedation. They're trying to maintain euvolemia. You're putting them in this low tidal volume ventilation strategy to reduce mortality, but they're really breathing over the set ventilator rate, or their PF ratio showing that it's getting worse, at least less than 150. Now we have to escalate. And what we do now is we paralyze the patient. We don't allow for them to breathe above what we want the ventilator to give them because it can injure them. So this is designed to reduce ventilator dysynchrony. And generally we do this again when a PF ratio is less than 150 and we've failed the other measures above. And it's been shown that if we can do that, we potentially can reduce mortality. Now let's say that the patient again is on ventilator, they're on neuromuscular blockade. You should always have them sedated. You should always treat their pain. You don't want them to be paralyzed and be aware or in pain. And so that's really, really needed if you have them on a neuromuscular blocker, which we already do. The next concept here is, if we have this patient on neuromuscular blockade, heavy sedation, goal euvolemia, low tidal volume ventilation strategy, and they're still having a PF less than 150, the data says you should prone these patients. And the reason why proning is really important is it reduces the dependent atelectasis. This is so kind of interesting here. So we do this when the PF ratio is less than 150 and they've failed everything above because it's been shown to reduce mortality. So we want to do mortality reducing things. If you look at a patient who's laying on their back, all this area here in the posterior portions is being compressed. And this is the areas that really, really we want to get good ventilation for. So if we go ahead and we flip them over, now we open up these areas here. And you're going to get good ventilation and good gas exchange. Again, you're seeing the component here that as we do this proning and then supine them, we see the effect of how we're kind of just moving the actual lungs and opening up these dependent posterior portions. And that's really going to improve oxygenation and reduce mortality. All right. Now, if the patient has pulmonary hypertension and they have RV dysfunction, there has been things that you can actually dilate those pulmonary vessels, and that may be somewhat helpful in refractory hypoxemia despite proning, neuromuscular blockade, low tidal volume ventilation, goal euvolemia, and heavy sedation. So you can consider this if they have pulmonary hypertension, RV dysfunction, and refractory hypoxemia. And if you've done all of those and the patient is still hypoxemic, VV ECMO or veno-venous ECMO is usually the best thing to do in these patients. What happens here is you take a catheter, you run it in via a big vein and go into this portion near the right atrium. You take another catheter and you're going to take the blood out through this pump, through this kind of like the console here. You're going to oxygenate the blood and you're going to return that back into the patient's bloodstream. And so if you look here, you have blood coming out. You're going to run through, oxygenate it, and then send it back in. So you're basically performing the job of the lungs. This is usually the thing that you do in the last case scenario when the patient is not able to improve, but there's just no good trials that suggest that this would be beneficial. But I have seen patients who have had this done and they've been able to improve and get off the ventilator eventually. So that's something that you would do in these patients. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.